Welcome to today's episode of podcast brought to you by ISCCM. We have the honor of speaking with Dr. Marlies Ostermann, a renowned nephrologist and intensivist based at Guy's and St. Thomas Hospital, NHS Foundation Trust in London. With an impressive background in acute kidney injury, renal replacement therapy, and critical care, Dr. Ostermann has made significant contributions in the field through her clinical work and research. Her expertise in the management of complex renal conditions, particularly in critically ill patients, has made her a leading voice in nephrology and critical care communities worldwide. We are thrilled to have her here today to share her insights and expertise. We welcome you, ma'am.
Thank you very much for the very kind introduction. I'm truly very honored to join this meeting. And I would like to start by thanking you, the Indian Society of Critical Care Medicine, and all your colleagues for the wonderful hospitality I've experienced in the last few years. And I've learned a lot at meetings in India and from discussions with colleagues. So I'd really like to express my sincere thanks to you and your colleagues.
Thank you, ma'am. It's an honor. So I'll start with the first question, ma'am. How far are we from diagnosis of acute kidney injury based on structural markers rather than functional markers? What are the current challenges we are facing in implementing these new biomarkers in clinical practice?
That's a really important question. So at the moment, the definition of acute kidney injury is based on urine output and creatinine, so functional biomarkers. And this is according to the consensus criteria as agreed by the KDIGO expert team in 2012. But clearly we have new markers. We have the structural markers, or sometimes called damage markers. And they've given us so much more insight into the pathogenesis, but also have told us that acute kidney injury occurs much earlier before the creatinine goes up. So these new structural or damage markers have truly advanced our field in acute kidney injury and given us opportunities to intervene early. Hence the call to integrate them into the current definition. So at the moment, the KDIGO definition or KDIGO criteria for AKI are the accepted criteria for acute kidney injury. But the Acute committee, expert committee, and experts around the world, and a lot of people also from India, have called for a revision to really with the intention to diagnose acute kidney injury earlier and to manage acute kidney injury earlier and prevent progression. So the KDIGO executive committee has taken this on board, and they have convened a new committee. And this committee is looking at a revision of the KDIGO AKI guideline, but in particular the definition. So hopefully by next year, we will know whether the official guideline, the official definition of acute kidney injury includes structural biomarkers as proposed by a lot of experts and the Acute committee.
Thank you, ma'am. Thank you for giving us clarity on the structural biomarkers.
I think you asked me about challenges as well. And I think the challenges are very clear. The problem now is that these biomarkers are so much more expensive. They are expensive for anybody across the world. And in my own practice here, I cannot afford to use them routinely in clinical practice. But in contrast to urine and creatinine, which are are affordable across the world. So we need to find a way of making them affordable to everybody across the world if we want to make use of them. And that's the big challenge.
I agree with you. I think the cost factor is actually the main thing, which is being an hindrance at putting it in regular clinical practice. Thank you so much.
Dr. Ostermann, now we will move on to the second question. The disease management of all the spectrum of disease has been changed, a shift to change to the phenotypic based management and even diagnosis and the way that we manage that. So how relevant is phenotyping of acute kidney injury clinically as well as the prognostication wise?
subphenotyping of acute kidney injury is absolutely essential. So the term acute kidney injury describes a syndrome of hundreds of different people with different types of acute and chronic illnesses and different types of acute kidney injury, and also in need of different forms of management. And acute kidney injury is never the same in two people. And to make progress, the only way to make progress is by subphenotyping, which simply means finding out the underlying cause of acute kidney injury, getting insight into the pathophysiology, and then managing patients accordingly so that we prevent progression and, in some patients, non-recovery. And I think the fact that we haven't done any subphenotyping so far is the main reason that we've not made any progress in therapies. We've got no therapy for acute kidney injury, but it is likely that there are individual therapies for particular types of acute kidney injury, hence the need to subphenotype.
Thank you so much. Future is always bright to get precision medicine or personalized medicine. This phenotyping definitely will help you to reach that goal. Thank you.
So coming to our next question about timing of initiation of renal replacement therapy, that has always been a matter of debate. So the exact timing of initiation for better patient outcome is still debatable with conflicting data from various randomized controlled trials. But somehow the early initiation of renal replacement therapy has fallen out of clinical practice. Why is that?
You're addressing a very important question, important for clinical practice. So early or accelerated initiation of renal replacement therapy before patients have an urgent indication is no longer advocated as a result of some landmark randomized controlled trials in the last 8 years. And so with the help of these really important multi-center trials, we've learned that patients who were randomized to early or accelerated renal replacement therapy did not have any benefit, did not have reduced mortality at 60 or 90 days. And furthermore, we've also learned a lot about the potential harm of renal replacement therapy, so diarrheal trauma. And this was in particular emphasized by the START-AKI trial, which showed that patients who were randomized to the accelerated initiation arm had a much higher risk of side effects, much higher risk of hemodynamic instability, and a much higher risk of still being on dialysis at 90 days and being chronically dialysis dependent. So it has emphasized and brought home the fact that renal replacement therapy really is a fantastic therapy for people who are critically ill and have advanced and progressive acute kidney injury, but it is a step up in care and a complex step which has potential side effects. So this is very, very important information. But it needs to be emphasized that these trials were done in a large number of patients with different comorbidities. And it is still possible that individual patients with different particular types of acute kidney injury, hence need for subphenotyping, may well benefit from some early initiation. We just need to find the better markers to indicate timing, the appropriate and optimal timing. Because if you leave it too late, as shown by Acute 2, then the mortality goes up again. So finding the right time where patients benefit from renal replacement therapy without being harmed is still an important task for all of us. And I strongly believe that's where subphenotyping, which we talked about earlier, will help us.
Thank you so much, Dr. Marlies. I think you brought a lot of clarity to that question. Finding the right time is most important in improving the outcomes in deciding the timing of RRT.
Dr. Marlies, we will move to the next question, which is futuristic, but that is something which is happening in the recent time, the role of artificial intelligence. what do you think the role of AI in the management of acute kidney injury with regards to renal replacement therapy also?
I think artificial intelligence or augmented intelligence is essential again. And again, it will help us in subphenotyping acute kidney injury, and it will help us closing some of the gaps which we currently have. So we have such a wealth of data in our own intensive care units, in our databases, and in major national or international databases. And with these new techniques, statistical methods, it is now possible to model populations, to address important questions, and to make sense of this wealth of data. And we already talked about biomarkers, which we struggle to afford in most countries, but these new statistical methods allow us to analyze our own data, to identify, again, subtypes of acute kidney injury that may benefit from one thing or may come to harm from one thing. Again, that's important, so that we advance and improve our management of acute kidney and most importantly, improve the outcome of acute kidney injury. So AI is absolutely an essential step towards better AKI management.
Thank you so much for that wonderful answer, because more and more is yet to come, and future will be good for all this kind of technology assisting you in coming to better personalized and precision medicine. Thank you, Dr. Marlies.
Correct. And I also believe that AI will acknowledge and take advantage of the fact that people are different. So people in different continents are different. Yes. And if we, with the help of AI, we can find specific characteristics of patient populations and allow personalized medicine. Because AKI in the country where I live, actually in the UK, is sometimes different from AKI in other places in the world. And we have to acknowledge that.
Correctly, sir. Correctly. Thank you.
So, Dr. Marlies, I'll come to a little controversial question also. And I see the students prescribing a lot of soda bicarbonate in patients with AKI in ICU. So where and under what circumstances do you consider giving soda bicarbonate in the treatment plan in your patient with non-oliguric acute kidney injury in ICU? What factors guide you in your decision making when you prescribe it?
It's a very important question. So a lot of patients with acute kidney injury need fluid therapy to correct hypovolemia and to establish euvolemia. A lot of patients are either acidotic or may have hyperkalemia. And in these patients, to either correct the metabolic acidosis or to help managing hyperkalemia, sodium bicarbonate is a very appropriate type of fluid. Now, the question remains whether sodium bicarbonate is better than other types of fluids. And this question is still unanswered, but I'm very hopeful because there are at least 2 randomized controlled trials trying to answer this question, one in France and one in the UK, looking at patients with advanced acute kidney injury, and they get randomized to sodium bicarbonate versus other types of other crystalloids. And I understand the trial in France has finished. So hopefully soon we will know whether whether sodium bicarbonate is more effective at correcting acute kidney injury and more effective at preventing renal replacement therapy. These are the 2 key questions in both trials, amongst a few other things. But do you improve the outcome, long-term outcome? Can we reverse AKI faster? And also, can we prevent renal replacement therapy, which is a fantastic therapy, but as we discussed earlier, also has harm and costs money and creates a lot of work for the bedside nurses.
True. Thank you for beautifully summarizing it. We are all waiting those randomized control trials to give us some results to show us how beneficial soda bicarbonate can be. Thank you so much, Dr. Marlies.
Dr. Marlies, next we go to the last question. We would like your inputs on a topic which is called as a drug dosing in CRRT. It's a very, very vast and expanded topic, but what general guidelines do clinicians has to follow when somebody is on CRRT and you have to prescribe the drugs in your ICU?
That's such an important question because we know, as you already said, that drug dosing is challenging when patients are on CRRT, and we have a lot of evidence now that patients are on CRRT are both underdosed and overdosed. So some patients come to harm from getting too much and the drug is causing toxicity. But there's also now increasing awareness that proportion of patients may well be underdosed, and this can be harmful, especially if we're talking about antimicrobials for patients with severe sepsis or septic shock. So finding the right dose of any drug, but in particular antimicrobials, is essential. And this is challenging because obviously renal replacement therapy is a dynamic therapy where sometimes patients have unintended interruptions, or they may have planned interruptions in treatment, and the dose may have to be adjusted. So what I personally, if ideally, it would be wonderful if we could do therapeutic drug monitoring. And this is possible in some places in the world. And if that's available, then you can dose the drug accordingly. Sadly, this is not available everywhere, and it's certainly also not available to me. I don't have facilities to do therapeutic drug monitoring apart from gentamicin and vancomycin. With that in mind, I do two things. I firstly follow the ESICM guidelines, which are available on the website, but also as an app. And secondly, I work very, very closely with our pharmacists and seek their advice. And thirdly, I emphasize the importance to my colleagues, and particularly our junior colleagues, and inform them that if the renal replacement therapy prescription changes and there are interruptions, or we stop, or the patient has to go to the operating room, then I always remind them to seek advice whether the drugs need to be changed. So it's the collaboration with pharmacists and the guidance from the ESICM app, which at the moment help me getting through these challenges until therapeutic drug monitoring is available to everybody.
Thank you. It was a difficult topic always, but you're given clear answers. Team approach, teamwork with your pharmacy, clinical pharmacist, and that's an important aspect when you prescribe medicines in CRRT dosing. Thank you once again for the clarity in answer, Dr. Marlies.
It's also the other thing which is obviously important to collaborate, to learn from your colleagues. And I've learned a lot. There's a lot happening in India again, and I've learned a lot from colleagues in India about monitoring, about drug dosing, and the challenges. So again, I'd like to thank you for this great collaboration and joint learning.
Thank you once again for your wonderful session. We will wind up here. That's the end of our section. That's the last question.